As you probably all know, we will have a webinar presentation of about 30 to 40 minutes. And then we have some time for discussion. If anyone is interested in posting a question to the speaker today, please do so by raising your hand using the application or by sending me a message through the chat. If you don't have a microphone, then I will read the questions to the speaker. But if you do have a microphone, I will give you the floor to do the questions yourself. All right, so then without much delay, let's start with the today's speaker. It's for me a pleasure to introduce all of you Jesús Silva-Rodríguez, who holds a physics degree and a PhD in medicine from the University of Santiago de Compostela. He has a diverse background that is spanning medical imaging physics, quantitative molecular imaging, Monte Carlo simulation, and software development. He spearheads the FDG-PET project, which is a multicentric national initiative aiming to validate new imaging biomarkers using synthetic PET images generated by computing simulations. In 2015, he was the co-founder of Q Biotech Health Intelligence, a cloud software firm specializing in neuroimaging quantification. He's been serving as a CTO for the company from 2017 until 2020. And he led the development of the company flagship product, which is called NeuroCloud. Last year, in 2022, Jesus joined the Movement Disorders Group at the Institute of Biomedicine of Seville, backed by esteemed Sarah Borrell Fellowship from the Spanish government, where he has continued the development of cutting-edge neuroimaging biomarkers, now in the field of Alzheimer's disease and other neurodegenerative diseases. So let me just thanks Jesus for his willingness to share with us his work today, and welcome to this CyberNet webinar series. And please, Jesus, the floor is yours. You can start sharing the screen. Go ahead.
Thank you very much for the introduction. So I will share my screen now, and I will share with all of you some of the insights of our recent research in the last 2 years in Seville, mainly focusing in the topic of the detection of co-pathologies in amnestic patients using FDG-PET patterns. So I have already been introduced. Just wanted to emphasize that I have a background in physics, and towards my research, I have been gradually transitioned towards a more clinically oriented researcher over time. So I'm not a clinician in background, just to keep in mind that for the questions, my clinics knowledge is sort of limited. And also, if you want to follow me through this journey, you can find me, of course, in Google Scholar. I don't know if the presentation will be shared. The link is complex, but probably you will be able to find me Googling if you are interested. So just a small index about what I will be talking today. So first, of course, I will do a small introduction that I obviously entitled AD or not AD. And afterwards, I will discuss a bit about the work we have been doing in our group about how to combine imaging and pathology to gain new insights on how to do a better interpretation of the findings that we can see in imaging for diagnosis. And then I will briefly discuss if we can use these new insights to detect the co-pathologies in AD, and also how can we use this knowledge to improve early dementia diagnosis. So as probably most of the presentations about AD that you have seen in the last years, I just wanted to start reminding you about the epidemic proportions of dementia right now. So today we can count, according to the World Health, World Health Organization, about 55 million people worldwide living with dementia, and the estimations put this number around more than 100 million by 2060, if of course we don't manage to do something to prevent the slow or cure the underlying diseases. According to the clinical statistics that I will try to challenge a bit during this presentation, around 60 to 70% of these dementia cases are caused by Alzheimer's disease. That, as most of you might already know, is caused by the accumulation of tau neurofibrillary tangles and amyloid beta containing plaques in the brain. Of course, tau and amyloid beta are both proteins, and this is why we usually say that AD is a proteinopathy, a concept that I will come back later in this presentation. And finally, just highlight that, of course, imaging, and very specifically positron emission tomography, plays a key role in the research and diagnosis of Alzheimer's disease and dementia in general. So thanks to a big effort in research for the last 20 years, we nowadays have radio tracers to study the presence of amyloid and tau in the brain, and also the neurodegeneration caused by the disease, so the cell death and the cell malfunction caused by the disease. And thanks to this, of course, we can pair imaging with novel frameworks like the ATM framework to very precisely place AD patients in the AD continuum. However, I will not talk about this today. It's just a reminder, and I will focus very strongly in FDG-PET, which is, in my opinion, very interesting because it's very widely available. So today we have more than 100 PET scanners in Spain, and all of them can perform FDG imaging. So it's a more or less available modality. And also it's one that we know very well, and we have used for differential diagnosis of dementia for more than 10 years now, and we have a lot of knowledge. So if we go back on how we would use FDG-PET, and we go back a bit to this concept of proteinopathies, we know that the accumulation of different proteins in the brain, and we can name 4 usual suspects, namely amyloid, tau, TDP-43, and alpha-synuclein. The accumulation of each of these will cause a very well-known pattern of degeneration that we can identify, and this way we can use the FDG.
You're mute, Jesus. I'm sorry. Your microphone seems to be off.
Okay.
Now, yeah, it's fine. Your voice came back.
From the beginning?
No, not from the beginning, just for the last 30 seconds or so.
Okay, that was weird then. Okay. So I just introduced the concept of FDG.
You have to share the screen with your presentation again, because we'll see it in a smaller screen.
Okay.
Do it again.
Okay, it's fine now?
Yes, that's fine.
Okay, so I just introduced the concept of FDG. I don't know if you all heard my discussion about that. And I was discussing that the FDG allows us to picture the neurodegeneration caused by different diseases in the brain. So if we have amyloid and tau, of course, we may be in the presence of a case with Alzheimer's disease. And we have defined very clearly a pattern of neurodegeneration associated with the disease. And we can do the same for others. So for example, if we have isolated TDP-43 in limbic areas, we will picture in a case of limbic age-related TDP-43 encephalopathy or late. For those not familiarized with this concept, this is a relatively novelly defined neuropathological change that is usually observed in older patients, and that produces a very similar clinical presentation with AD, but with a much slower cognitive decline. And of course, we can progress in this reasoning, and we have tau and TDP-43 we may be seeing a case of frontotemporal lobar degeneration. And if we have alpha-synuclein alone, or even paired with amyloid, that as amyloid positivity is very common in this disease, we may be seeing a case of dementia with Lewy bodies. And again, we have defined through time a very well-defined pattern of neurodegeneration that we can picture with FDG for this disease. So we know a lot of patterns and how to use them to do differential diagnosis. However, there is no rule on how to combine these pathologies. In fact, having one proteinopathy incredibly increases the probability of having more. So we can see more complex combinations. For example, something like this. So in both these cases, we have amyloid and tau, so we have Alzheimer's disease, but we also have a contribution from a different source, in this case from alpha-synuclein, and in this case for TDP-43 pathology, sorry. So in these cases, we might say that we are seeing cases of mixed pathology, or more concretely, depending on the clinical presentation, if we have an amnestic presentation typical of Alzheimer's disease, we might say that this is AD plus LB or TDP-43 co-pathology. And of course, an obvious question would be, what is the FDG-PET pattern for this? So you might say, okay, this is a very specific case because you have all these possible combinations and all these pathologies, and you are focusing in a very specific group, that is those that have AD and also have a contribution of alpha-synuclein or TDP-43. But this is in fact relatively common. So if we go to neuropathology bibliography, for example, I really like this paper from Robinson and collaborators in Brain in 2021, because it focuses on patients with a clinical AD diagnosis. So we know these patients have a typical amnestic presentation. And in this paper that analyzes two separate cohorts, so here we have cohort 1 and cohort 2, we can see that up to 70% of clinical AD patients will present with some sort of co-pathology, rather alpha-synuclein or TDP-43. These proportions increase with age and also with tau NFT staging. So due to these numbers, we may say that pure AD is in fact relatively rare. So understanding the effect of these co-pathologies in the neurodegeneration phenotype is really important. Furthermore, it's also really important to identify these patients in the clinic, because these co-pathologies have been associated with a faster cognitive decline, and also in the early phases in MCI, with a higher MCI to dementia conversion rates. So to study this, of course, is very complicated, because we need to identify very well patients with co-pathology. And as we don't have a standardized way of identifying these co-pathologies in the clinic, we have to go to neuropathological data. And we have to search for a data set that has neuropathological data and also FDG-PET images available. And we found one cohort that has all this information and is very interesting, and is the autopsy cohort within the Alzheimer's Disease Neuroimaging Initiative. So when we started working on this, the cohort was 58 patients, but it has been growing over time, and all these patients have been followed to death. They have neuropathological examinations and also FDG-PET scans, and all of them have a diagnosis of AD dementia or amnestic MCI. And of course, they have standard scales for AD pathology, for LB pathology, and for TDP-43. And the first question that we wanted to answer using this cohort is, can we use FDG-PET to detect the co-pathologies? And here we have the results from our experiments that were published both this year in Alzheimer's and Dementia, and also in the Journal of Nuclear Medicine. And as you can see here, we have classified the patients in neuropathological groups. So patients with only AD here and here, patients that only have very interestingly late pathology or Lewy body pathology, and also mixed cases with AD plus late pathology or AD and TDP43 co-pathology, and AD and Levy body co-pathology. So these are the mixed groups that we are interested in. And as you can see here, the pattern of neurodegeneration is very similar between these two groups, and also is very similar between these two groups. Yes, we can see here that the intensity of the neurodegeneration will be slightly higher in the groups with co-pathology, but certainly this difference will be not enough to produce an accurate diagnosis in an individual basis. So to the first question that we asked, can we use these new insights to detect co-pathology? Sadly, I think the answer would be no. And if you think about it, I have reflected about this over time. This is not as surprising because we have defined these patterns based on clinical data. And we know from neuropathology that most cases will have co-pathologies. However, we also had some, we also gathered other interesting knowledge from these papers. And it's related to these other groups. So of the patients with a clinical diagnosis of AD in a very well studied cohort, almost 40% of them showed late pathology without any evidence of AD. So we may consider this a misdiagnosed late case. And similarly, for the Levy body pathology, around 12% of the patients showed Levy body pathology without any evidence of AD. And in these cases, we can see a very well differentiated pattern associated with this pathology. So here we have the limbic pattern, very, very, very limbic without any other contributions in the parietal regions or the lateral temporal lobe that would be typical for AD. And here we can see the typical Levy body dementia parieto-occipital pattern with a very well preserved medial temporal lobe, even in clinical presentations typical for AD. Additionally, despite AD was the dominant pathology defining the neurodegeneration pattern in most mixed cases, a small subset of the co-pathological cases told us a different study. And I have here an example. So, for example, if we see these three cases are mixed AD and Levy body pathology cases, but in this we observed some other signs of neurodegeneration caused by the Levy bodies, for example, in substantia nigra neuronal loss. And we can see that in these patients with other signs of Levy body related neurodegeneration, we can clearly see the typical Levy body posterior occipital pattern with a relatively spared medial temporal lobe in all cases. So we will be able to use these patterns to detect first patients with a typical presentations where other pathological features may be mimicking AD clinically, and also mixed cases where this co-pathology may have a more relevant role in the neurodegeneration. And the next obvious question is if we can use these new insights to improve the diagnosis in the clinic. We have thought about this, and we have done this for both dementia and pre-dementia patients, but I think this is particularly interesting in pre-dementia stages. So when we focus in early diagnosis, because in these cases, diagnosis may be more challenging. And as a proof, we can go to clinical data, and we can see, for example, that in cases with a later diagnosis of dementia with Levy bodies, memory loss would be the debut symptom. So in these patients is where really these neurodegeneration patterns can point us to the right direction. So in following experiments, we wanted to understand how these differential patterns suggesting Levy body pathology or suggesting underlying late pathology can help us to do a better diagnosis in the context of clinical AD. So in our first experiment, We enrolled 909 participants from the Alzheimer's Disease Neuroimaging Initiative who had a baseline clinical diagnosis of amnestic MCI and also FDG-PET scans available. To detect which of these patients have the typical pure LV pattern that we were observing in the autopsy cohort, we trained a maximum entropy classification algorithm to separate between the pure AD and pure LV groups in the autopsy experiment. And we did so by using three imaging biomarkers that are known to distinguish between AD and dementia with Lewy bodies, namely the cingulate island sign ratio, the occipital SUVR, and the medial temporal lobe SUVR. Once we had our classification algorithm, we classified the 909 images from amnestic MCI patients in three groups: no hypometabolism, AD-like, and Lewy body-like hypometabolism. Once we had our classification, we wanted to compare of course, the AD-like and the Lewy body-like patients. And we did so in clinical variables, starting with the global cognition, as stated with the mini mental state examination. We also studied the domain-specific composite scores for memory and for executive function. And we defined a novel cognitive profiling variable that is the difference between these two composite scores that will give us a cognitive profile. So it will tell us if a patient cognitive decline is more memory predominant or more executive predominant. Of course, we expect the AD patients to be more memory predominant and the Lewy body-like patients to be more executive predominant. And to go a bit more into the diagnosis of dementia with Lewy bodies, we also wanted to study neuropsychiatric symptoms. Unfortunately, the MPI questionnaire is available for these patients, and we focused particularly in the appearance of hallucinations as a neuropsychiatric symptom of dementia with Lewy bodies in these patients. And finally, we also wanted to understand the presence of AD pathology in these patients. So in the previous work, we observed that this could be caused by a misdiagnosis, but also we can see this in mixed pathology. So we wanted to know a bit about the AD biomarkers in these patients. And to this end, we analyzed the amyloid PET and tau PET for these patients. So going to the results, after our classification, you can see here the patterns of the patients classified as AD-like and Lewy body-like. And interestingly, we found that around 12% of the cohort was classified as LV-like, which is a very similar proportion to what we observed in the autopsy studies. And of course, we have a very nice distinction here and also in the biomarkers, because of course we use them to do this classification. This is more of a sanity check. And if we go to the demographics, we don't see differences in age, male proportion, education, or even HAPE-E4 positivity under these patients. This is very interesting. But if we go to cognition, we can see that no differences in global cognition. So a mini mental state examination is similar between groups, but the AD-like group is much more memory impaired than the Lewy body-like group, which of course, using our profiling variable, defines a more executive predominant cognitive profile in the Lewy body-like group compared to the AD-like group. If we go to the imaging, we observe that the amyloid load was significantly lower in the Lewy body-like. This was confirmed both by the voxel-wise analysis and by the global SUVR. And if we go to tau PET, we see a similar story. So the tau load was significantly lower in the Lewy body-like compared to the AD-like group. But very interestingly, if we see the contrast here, we can see a relatively high tau load in the occipital of Lewy body-like patients compared to the rest of the brain, where the differences are more notable. And this is a common finding in dementia with Lewy bodies, occipital tau accumulation. Regarding the longitudinal analysis of clinical data, we observed a slower global cognitive decline in the Lewy body group. Also, that was primarily driven by a slower memory performance decline, and this ended with the Lewy body-like group transitioning towards a more executive predominant profile over time. We also observed a lower MCI to AD conversion rate in the Lewy body-like group. And for me, my favorite result in this report, the most interesting, is if we go to analyze neuropsychiatric symptoms, we can see a much higher rate of patients developing hallucinations. In the Lewy-like group. So with a hazard ratio of almost 2, 27% of the patients classified as Lewy body-like will develop hallucinations over time. We have a follow-up span of around 6 years here. And this 27% is reduced only to 16% in the AD-like group. So from this first experiment, we may conclude that a sizable group of elderly patients with amnestic presentations typical for AD exhibit a posterior occipital hypometabolism pattern suggestive of Lewy body pathology. This pattern associates with a lower AD biomarker burden, a distinctive dysexecutive cognitive profile, and a higher risk of developing hallucinations over time. This may have important implications for both clinical management and AD clinical trial recruitment. And in the clinic, that was our focus in this work, patients showing this differential hypometabolism pattern should be subjected to a special consideration, even without any a priori clinical suspicion of underlying Lewy body pathology. And of course, if you want to know more about the methodology behind this work, I invite you to read our full report that has been recently published. Now, regarding late TDP-43, we performed a similar experiment, starting with the classification of the 909 participants into a similar AD-like group and a late-like group. In contrast with the previous work here, we used a pattern matching approach to classify the patients in the two groups, mainly driven by the fact that the late is a recently defined finding, and we don't have very well established biomarkers distinguish AD and late based on PET imaging. So we chose this pattern matching approach that is much more versatile. And after the classification that, of course, as previously, gave us 3 groups, no hypometabolism, AD-like, and late-like, we examined clinical variables, so the same mini-mental domain-specific composite scores and cognitive profiling variable that we did before. Additionally, we studied genetics, starting with ApoE3, but also analyzing TMEM 106B that has been associated with a higher risk of late. And this is an ongoing project yet to be finished. So as a preliminary result, we studied AD biomarkers in CSF and also the tau PET that we evaluated using quantitative measurements and also a recently FDA approved visual reading method. So after the classification, we had a slightly different AD-like group because the classification process was different, with 144 patients, and a late-like group that has 105 patients. The first interesting finding of this work is the difference in age. So we can see that the late-like patients are significantly older than the AD-like. This is an interesting finding, of course, because as I stated in the beginning, late is usually common in older patients, and also because the older age give us some assurance that what we are seeing here is not early onset limbic predominant AD. If we focus on cognition, we can see very similar MMSE in the baseline, very similar memory performance, but a significantly worse executive performance in the AD-like. And towards time, we see a much slower decline in all the indexes in the late-like group. Again, this is a sign that we might be observing late, because as also stated in the beginning, these patients are characterized by a slower progression. Going to genetics, we saw a much higher proportion of APOE positivity in the AD-like, so 70% APOE E4 positive compared to 42% in the late-like. And in the AD-like, and in the TMEN106B, sorry, we didn't find any significant differences, but we observed a trend to having more TT and TC patients in the late-like group. And just I'm about to get to the end. We check the AD biomarkers in CSF. We can see a worse amyloid status and worse tau status in the AD-like, with significant differences in both cases and a pretty respectable effect size. And in tau PET, we see a similar story with quantitative analysis of the BRAC areas, much higher SUVs, in the AD-like group for the 1, 2, 3, 4, and 6, 5 areas. The AD-like much higher, and using this FDA-approved tau PET visual method that has been approved recently to be used in the clinic, we observed a positive rate in the visual analysis of 92% of advanced tau pathology in the AD-like group, compared to only 40% in the late-like group. So we may conclude that amnestic MCI patients with temporal limbic FDG-PET patterns suggestive of late show a clinical and biomarker features that deviate significantly from prodromal AD, starting with older age, slower disease curves, less abnormal amyloid and tau, and less likely to be APOE E4 carriers. Of course, enriched for TMEN106B, just to remind that these were not significant in our core, these differences. And a subset of these patients also show advanced tau signal, so a small proportion, and thus could overlap with a limber predominant FDG-PET subtype of AD, or also a PART. In the future, we would like to perform a better characterization of early, late versus AD, and also to try to distinguish late from other MTL-focused pathologies like PART, HD, or LPAD, limbic predominant AD. With this, I come to the end of my presentation. Just to remind you that if you want to learn more about these topics, don't miss the following webinar in 2 weeks that will be held by our neuroimaging PI in Seville, Michel Grotte. And just to conclude, acknowledge all the wonderful people in our group, and also our collaborators in the University of Gothenburg that have aided significantly in this research. And that would be all from me.
All right, thank you very much, Jesus. Very nice presentation. So now the paper is now open for discussion. As I said earlier, if anyone is interested in posing questions to Jesus, please do so by using the raise hand option in your screen, or by sending me a message through the chat, and I will give you the floor to pose the question yourself. While we wait for the next, for the first question, let me just also remind everyone that the CyberNet webinar series are held on Thursdays at 3:30 p.m. every other week. And if you're interested in looking at the program for the coming webinars, we just heard that the next one will be in 2 weeks. So we have already the program ready for until the end of the year. And we have now in the process of filling up the program for the first part of next year, 2024. So if you're interested also in participating in this webinar series, please send us an email message stating your interest, either to myself, Miguel Medina, or to Teresa Iglesias, who is the responsible for the training program. And I will try to accommodate a convenient day for you to present. Okay, so any questions? Don't be shy. I don't see any raised hands. I'm checking the chat. Nothing coming in there. No questions? Just a brief comment that during the presentation, Jesus alluded to the whether the presentation itself will be distributed. We normally don't do that, but I'm sure that Jesus will be happy to make the presentation available if you just contact him directly.
No problem.
Okay, well, we'll be available in a matter of a few days, maybe a couple of weeks. It will be the recording of the presentation, and that will be in, you can access that through the CyberNet webpage. Okay, any questions? Okay, I don't see any raised hand or any message through the chat. So let me make a last call for questions, just in case anyone is still interested. Otherwise, I think we will have to end the session here. Remember that the recording will be available at CyberNet websites in a matter of a few days, couple of weeks. So if you're interested in going there, or anyone knows someone who hasn't been able to attend, the presentation will be there. And since I don't see any raise hand, or let me just yeah, no message through the chat either. So okay, so we're gonna end the session here, but not before thanking Jesus for a nice presentation and his willingness to share with us his work. Thank you everyone for attending today's webinar, and I hope to see you all in the upcoming webinars. Jesus, thank you very much.
Thank you for inviting me.
Okay, have a great day.
Bye-bye.
Bye-bye.